So this is essentially the sixth time we've gathered people together and one of our biggest. So thank you all very much for taking time out of your practice, out of your lives, to spend a few days with us on what we hope will be a very exciting program. I do have to say that many of you should know who I am or do know who I am. I'm Colin Matheson. My team, Sandra Diver and Bruce Arnold. So the three of us, as you can see, are not young. We have been doing this for a very long time, and many of you we have met along our journeys. We love what we do, but most of all, we love the people that we get to meet. So if you haven't met us, please come and say hello. 2 weeks ago, we held a user meeting for some doctors in Australia. And Dr. Stuart Frost, who is quite a well-known Damon speaker, was lecturing for the day. And Stuart asked an interesting question of the group. He said, how many of you have met Dr. Damon, and could you share with me the lasting impression you gained from him when you met him? And as you look at Dr. Damon, the first comment from the room was, he's got a very big head. And you'd have to say that's true. Dwight has a very big head. Other comments were, I was blown away by the quality of his cases. He has beautiful orthodontic results. Others were how inspiring and motivational he is. His commitment to excellence, which Dwight has always been very passionate about and about sharing. But mostly it was his big head everybody remembers. And I think when you think about what Dr. Damon did, it's pretty good. We're lucky that he does have a big head, because not only did he develop a bracket, but he spent years and years working on mechanics that we could use in conjunction with the bracket to maximise treatment outcomes. Now, if you think about that process, it's trial and error. You try something, just as you do in your practice. You wait 3 months, 6 months, 9 months, until you can decide whether that change created a better outcome. And that's an enormous undertaking. And Dr. Damon spent years doing that. And along the way, he came up with some core mechanics that work incredibly well with a passive self-ligating system. Now, every doctor in this room, every speaker, orthodontists have one thing in common. They like to tinker. They like to try. They like to adjust. And that happens. That's part of the process. But more and more you talk to some of the US lecturers, and they will say, you know, I've been doing this for a long time and I'm getting a little frustrated because I still can't get the same results that Dwight got. And so more and more they keep coming back to the core mechanics to remind themselves of what worked for Dr. Damon. So sometimes you stray from the path. Maybe it's a good change. But it is really important sometimes to remind yourself of the core mechanics so you pull yourself back, get a good benchmark and kind of guarantee success. Because Dwight did develop this as a system. And some people say that's a dirty word in Damon. But the wires he uses, the prescription in the bracket itself and the mechanics all work together to hopefully help you create great outcomes for your patients. And that's why today is an important day. And great to see so many people turning up, even those of you who've been using Damon for a long time. So today we've brought one of the best at reminding us of what important core mechanics are. And it's Dr. Frank Bogdan, who hails from New Jersey in the United States. Now, many of you would have heard Frank lecture over the years. He's travelled extensively. He graduated and taught at the University of Medicine and Dentistry in New Jersey. and he lectures all over the world and is a regular speaker at the US Forum as well as other international forums. Frank's looking very relaxed these days because his son took over his practice. He still works there, but he does spend more of his time now enjoying the sunshine in Florida. So I would like to welcome to the stage a very relaxed and impressive Dr. Frank Bogdan. Thank you.
Thank you. Thanks, Colin, for that intro. Basically, what you're looking at is a picture of me back and Dr. Damon in 2002 in Monaco. And if you just look at my smile, you'll see it's very different from what you're seeing me walk around with today. Okay. The smile I have today is redone when I was in my 50s. I went into the Damon system. I came into the office one morning and I told my son, "We're putting braces on me today." He says, "Dad, what are you, crazy?" I said, "No, I'm tired of creating all these beautiful smiles for adults. All right, I want to do that for me." So back in my 50s, I went back and did it all over again. Right. So, and I'm very excited about the result I got. And, you know, again, at my age, I think Damon braces absolutely have an effect on the facial features, makes people look younger. You'll see that in many of my cases. And at my age, I need to look younger. So, all right, so here we are. This is the title of my presentation, and basically it is going back to basics. But there is an evolution of the thought process. So when I started in 1997 using the Damon system, it was very, very different. We had 3 arch wires. We had 014 night tie, not even copper night tie at that point. 014 night tie, 1625 night tie, 1925 steel. That was it. 3 wires. So it has definitely evolved over the years. I was a part of the 3rd Damon Asian Forum, as you can see, and it was again in Bangkok. How about that? So this is a return to Bangkok for me. I've been here probably 4 times, but this is my 2nd Asian Damon Forum. And you can see there's a cast of characters that are still present here. And this is where I met Chris Chang and John Lin, and that's been a blessing in my career. This is the office in Bayonne, New Jersey. I've been in practice for 40 years. So you can look at that 2 ways, right? Either I have a lot of experience or I'm very old. One or the other, right? I prefer to think of it as experience, right? This is our new office. I had bought the building next door to me. All right, and this is our front desk, our clinic. We have 6 chairs, in addition to 2 rooms with exam chairs. That is my son, all right, and some of our staff. And you probably can see that I have braces on. I don't know if you noticed at that forum in 2009, I had braces on. So I was in the Damon system at that point in time. The other hat I wear is this. I'm an assistant clinical professor at Rutgers. Used to be called University of Medicine and Dentistry of New Jersey, which was a mouthful. Now it's called Rutgers University, and of course, most people have heard of Rutgers because of football and basketball. Right? I gave my first lecture there on PSL in 2001. Right? And I've lectured internationally since 2002. All right, this is my senior class of residents that just graduated. All great kids, and it's just a pleasure for me to teach these young residents. Keeps me abreast of all things that are going on, and they challenge me to continue to get better. So I began utilizing the Damon system, as I said, in 1997. That was 20 years ago. I started teaching the system 15 years ago. And I started my orthodontic practice 40 years ago. So what does that tell you? If you do the math, I did conventional mechanics for 20 years. And I've done Damon now for 20 years. So I pretty much have equal experience in both. I've been all over the world. This is, again, in India with Chris, in China, in Thailand, multiple times. You notice that Chris Chang shows up in a lot of these pictures all the time? I said, Chris, are you following me? And John Lennon. Every word, this is in Shenzhen, China, at their China Forum last year. These are my children. Well, they're a few of my children. This is my daughter, obviously my daughter's wedding. And I just want you to look at their smiles. Would you be surprised that none of them were treated with the Damon system? They still have nice results, don't they? So I'm not here to tell you that conventional mechanics is bad. I'm just here to tell you that I don't have to put my patients through what I put my kids through. My youngest daughter here, she had a pendulum appliance because I stopped using headgears. And I thought that was the greatest thing since sliced bread until I had to live with her every day. Go home and listen to her complain about that appliance. So if you want to learn what you're doing to your patients, treat your children. Because then you get them 24 hours a day. So there's a lot I can do not to torture my patients today. I hate to tell you this because now you're going to know what that 40 years is about. I have now 13 grandchildren. That's a lot, right? So that could make me very old. I'm 103 tomorrow. No, I'm only kidding. All right. This is my youngest daughter, as I showed you. This is my youngest grandchild, born in October of this year, right before we went to South America. And my wife and the there. So a little bit about my lecture style. I don't take myself too seriously, and I do like to have fun. So people that have heard me lecture before know that I do enjoy it, right? I like to have fun, but I also take my orthodontics very seriously, right? See, now could that be Cleopatra? Oh, she was pretty ugly if that was the case, right? I can't help myself. And then my grandchildren are just like me. They want to get into the picture, so I promised them I would show their picture on stage. These are two of my grandchildren, and of course they went through Damon braces. Oh, they were not really good results. They were not good patients. All right. This is in South America, in Argentina, just this past year. It was very exciting. This is my second trip back to South America, and I really enjoyed that. This is Iguazu. If you haven't been to Iguazu, I would tell you put it on your bucket list. It's the most beautiful waterfalls in the world. It's incredible. I mean, look at that rainbow. This is my wife at Iguazu, and I promised my wife that I would show you her in the shower. No, I'm only kidding. All right. This is the chairman of the department at the university there in Buenos Aires. And we were invited, after the lecture at the convention center, we were invited to a reception at the dental school that evening. And there was a series of speeches all night long. And it was like amazing. I was sitting in this seat in the front row. I couldn't leave. I had the chairman of the department right next to me. And they did at least an hour and a half of speeches, of which I didn't understand a word because it was all in Spanish. So you can imagine how great that was. But I did understand this last guy. So I'm going to let you hear him. It looks like he's yelling at everybody, right? Uh-oh, what happened there? Now, everybody can understand that, right? I mean, he's a famous tenor in South America, and he's a dentist. So what's my objective today? So for 20 years, I've been doing this, right? And I've looked at teeth and alveolar bone moving differently with light force and low friction mechanics, all right? And, you know, that's what we're going to talk about today. There are a lot of misconceptions and preconceived ideas about the Damon system. And just like Colin Mathewson said, we get doing this and we start tweaking things that we shouldn't be tweaking. So we're going to try and untweak you today for some of the things that we do, all right? So let's talk about what really passive self-ligation is. It is a tool that has simplified mechanics and simplified protocols. But it's not a cookbook. You can't do the same thing in every case. You still have to be an orthodontist. Right? It clearly reduces friction. And when we reduce friction, that changes the biomechanics. We're going to talk about that. Because biomechanics are different in passive self-ligation than they are in conventional mechanics. Muscles impact our cases. Probably the most important thing that I can explain to you today. Muscles have an effect on the dentition when we don't tie down teeth. There is a functional effect. It utilizes light force, and I can tell you that the lighter the forces over the years, the lighter we've gotten with our forces, the better the cases come out, and the more dramatic the response is. That positive periodontal tissue. The tissue response is incredible. I've never seen that in conventional mechanics or high force mechanics. Disarticulation is a key factor, and early light elastics are a key factor. All right? So these are a couple things that are not in the workbook. Disarticulation, we didn't talk a lot about that in the early years, and early light elastics. It is not a non-extraction technique. And I know you know that here in Asia, but in my area, I am probably the one speaker that extracts the most in my cases because of my patient population. In my town where we practice, we have Hispanic, Black, and Asian. So we do more extractions than the average speaker. So we're going to talk about extractions today. It virtually eliminates the need for most auxiliary appliances. All right, clinical observations. The overwhelming majority of malocclusions are dental alveolar in nature. Period. Muscle function imbalance is the biggest player that creates malocclusions. So if the majority of malocclusions are dental alveolar, pure skeletal malocclusions should be a minority of the problems we treat. So we do get those occasionally. And yeah, we do surgery when we have to. So nobody's going to treat this without surgery. But these are so far and few between. And later, at the end of the day today, and then on Friday, we're going to talk about problem cases. We're going to look at some class 3s that should be surgical, all diagnosed and treatment plan for surgery, and yet we didn't do surgery. So how about these class 2 cases? Are these skeletal problems? Well, we used to say that all the time, right? And we use an orthopedic appliance to correct them, whether it be Herbst or Mara. All right? And that's what I use. I use a Mara. All right, but we know from the literature, even with the Frankel regulator, this is by Robertson, and look when this is published, 1983 in the AJL. What do we know? 2 groups of patients treated with the Frankel, class 2s and class 3s. And what was the conclusion in terms of the result? Principal changes from this appliance are dental alveolar. How about that? That's what I saw. When I was using Frankel early in my career, I saw arches expanding, and I didn't use a rapid palate expander. And so it made no sense to me to be splitting a palate when I was watching this dramatic change in the arch just because we shielded the muscles away. So it made me start on a different path. The last rapid palate expander I used, even in a young patient, was 1982. It has nothing to do with Damon. I did use rapid palate expanders in the 80s, using surgically assisted rapid palate expansion on non-growing patients. How many people have done SARPs? Raise your hand. Surgically assisted rapid palatal expansion. Nobody? Some people have, right? All right, it's the only way you can split a palate and expand it, supposedly, right, in an adult. Right? Do any of those patients love you? No. No. That is like the worst surgery you can put somebody through. Well, suppose I told you don't have to do that anymore. Because if it's dental alveolar, we can change that bone at any age. as long as what? They're breathing. They have to be breathing. All right? If they're not breathing, we can't change it. All right? Okay, so my training was the key. I mean, I came out of school trained 50% beg, 50% edgewise, but I also found both of them to be deficient when it came to treating these so-called skeletal problems. So I started using Frankels and activators and bionators. And the last one I used was lip bumpers. And lip bumper, you'd be surprised, is a functional appliance. All right, we'll prove that to you. All right? So later in my career in the 90s, and again, always in an attempt to treat more cases non-extraction, I used a lot of settling mechanics. All right, so what about this next case? Can we push the envelope? Look at the gummy smile. Look at that bone. Does that look normal, the premaxillary area? So what would you do here? Surgery? TADS? Or dentalveolar modeling? Well, at this time, we didn't have TADS. Not here. You guys probably had it over in Asia here. So we just intruded. We torqued and intruded. I used a class 2 corrector, the Mara. But look at the amount of torque and intrusion. And look what happens to the bone. It models. It changes shape and size simply because we put pressure on the teeth. And with light force torque, you can see we didn't take the roots off. That's the beautiful part about the Damon system and light forces. And we take and put those teeth back in their smile. No surgery, no TADS. We didn't have TADS at that point. But we could use TADS today to do that. So clinical observations. The tissue response is much better. Bone and soft tissue. And I'm going to prove that to you all day. Something's wrong with my mic? Now let me get rid of this. Maybe that helps? Better? Everybody knows who I am, right? I can throw this out? Okay. The tissue response is much better, bone and soft tissue. So if we look at this woman, her chief complaint is, I hate to smile. Look at the tissue around this tooth. Look at this tissue. Close up. If we torque and intrude that tooth, look how the tissue response changes. There's no grafting done there. That's simply torque, right, intrusion. So we addressed her chief complaint, but we also dealt with the periodontal issue. Right? Positive response. So form does follow function. Now, when I was in school, Melvin Moss was a big deal. He was in the 60s. He was at NYU, right across the river. And if anybody ever took a course with Melvin Moss, you know he was a really big guy. Very intimidating guy. He was about 6'5", 6'6", very intimidating. You never asked a question. He was like the god of research, right, at that point in time. But everybody thought he was crazy. They thought he was a lunatic, right, because he was talking about stuff like functional matrix, how we can develop bone, or bone was meant to have a genetic potential, and if you upright teeth, bone would go with it. That was the functional matrix. Guess what? He was right. You know, he also said that the mandible didn't grow at the condyle. That was like heresy back then. Mandible didn't grow at the condyle. And they laughed at him. And you know what he did? He took a whole bunch of rabbits, he cut the condyles off, and guess what? The mandible still grew in its functional matrix. So he laughed back at the profession. So that hypothesis was in the 60s. So we knew all this stuff. And I had the benefit of being right across the river from this guy and got to listen to him quite often. So if we minimize friction, right, and keep our forces low, there's a functional effect to the Damon system, allowing muscles to impact your case. We call that modeling of bone. Modeling. Take a look at this. That's a lip bumper. How did this happen? This is size corrected, and this is a year of treatment with just a lip bumper in there. No brackets. Who moved those teeth? It wasn't Damon brackets. It wasn't conventional brackets. It was just muscles. Okay. The bicuspid incisor is upright because there's a change in the balance of forces. You keep the lip and the cheek away from that dentition, and the tongue is developing the teeth or the dentition from the inside. Look at the uprighting of the bicuspids. Look at the incisors that line themselves almost perfectly without any physical appliances. That's what we saw in Frankel. Okay. So getting tripped up is easy. Understanding the biomechanics of the system allows us to set up different sequences. And this is where of treatment, arch wires. We talk about a wire sequence, but that doesn't mean we use that all the time. Right? We have to adjust according to the case. Right? So when we didn't do that, we got tripped up many times. And my penguin friends will illustrate that to you. So getting tripped up was easy, especially in the 1990s. 97, we didn't know what we were doing. As Colin said, we were flying by the seat of our pants. We didn't know what was going on with this system. All we know that teeth were moving differently and they were moving better. In 2000, in the anniversary journal of the AJO, Dr. Burstone said this: the scientific basis of orthodontics rests on a knowledge of anatomy and physiology and growth. But mostly it's about biomechanics, a force system of dental and orthopedic correction. That's what orthodontics is. He also said that we need to develop a mechanics plan, and its starting place should be a force system to optimize tooth movement with minimal undesirable side effects. I love this guy. I didn't understand. It took me a long time reading his articles on superelastic wires and stuff like that to get it. Has anybody ever read Burstone and superelastic wires? It's a good thing to put on your nightstand if you have insomnia, isn't it? Right? Because it's easy to go to sleep with that. Right? But this is what he said about our future. The 21st century, there will be a major shift of orthodontic techniques from a biomechanical approach to treatment. And with that will come rapid changes in treatment procedures and concepts. That's what I believe is the Damon system. Once we took away friction, we started to see a new or different biomechanics. And that's what we were trying to figure out all these early years. How do we use this new and different biomechanics? Because it's not the same as conventional. I did it for 20 years. It's not the same. Why would I do something like this? Looks a little crazy, doesn't it? But I understand the biomechanics. And then, with teeth almost perfectly straight, I take out teeth. Does that make any sense? So right away you should start thinking that crowding is not the issue for extractions, right? Because if crowding was the issue, then you'd really think I'm crazy looking at this one, right? That is crazy looking, isn't it? But you're going to find out how we diagnose and treatment plan these cases and why I did this. We're going to look at these cases today. Or this. In this case, I bypassed only one quadrant. What was the reason? We're going to take you through that. What I'm going to try to do today is you get in my head. Look at what I'm looking at. Understand how I look at a case and how I treatment plan a case with this new biomechanics. Because that's what it's about. It's using the tool that we have, this beautiful new tool, and using it the right way. Because so often we get off track. We start doing a little tweak here, a little tweak there, another tweak here, and then we get in trouble. And the reason we get in trouble is because we don't understand where we got in trouble. Right? That's what we're going to talk about on Friday. So on Friday, we're going to talk about troubleshooting cases. We're going to talk about, and we're going to take you inside the bracket. You'll be able to see some of that, what's going on, all right, why we have these problems in finishing, okay, and a whole host of other things. Friday will be exciting, okay. So diagnosis, it comes down to this. The face and the skeletal pattern, that's where we start. But with passive self-ligation, we have to take into consideration muscles. So how do we know what the muscles did? We look at the dental alveolus. That's what tells us what kind of muscles we have. We don't sit there and pull on somebody's cheek and say, they got good muscles. or they don't have good muscles, or pull their lip out and we can pull it to the floor. Now they got weak lips. No, it's about what it did to the dentition. What happened? That's how we tell. Then that allows us to determine what we can do in the case. And if we understand the biomechanics, we set up our cases, like you just saw. 4 different, totally different setups. Okay. So there's that lip bumper case, right? We just looked at. The lip bumper is self-limiting. Notice these teeth can just go so far. The tongue muscle is going to put them where they need to go, and that's it. But when we get to PSL, what limits our treatment is the diagnosis and the biomechanics. So look at these cases. They're very similar, right? They still had ease present. Okay? One just falling out. Still had crowding. This case even looks more crowded, right? With Damon. And look how this lined up, and look how this lined up. How long did that take me? A year. How about 6 months? In more crowding. And we're going to look at this case. That's Karina. So we'll be coming up on Karina this morning. And we'll see how in 6 months, with 3 round wires, that all lined up. And teeth did not flare, just like the lip bumper. The limit, the self-limiting aspect of the Damon system is you, your diagnosis and treatment plan, right? Not the lip bumper. All right, so why would I do this? That's Karina. That's the arch you just looked at. All right? So we're going to look at Karina this morning. All right? And we're going to see why I would do something that crazy looking. And how about if I told you she has root resorption on her 2 centrals? She does. She fell as a little girl. So it is not a non-extraction technique. Now this is the list. And we're going to take apart this list little by little. And I chose to talk about extractions first because I know in Asia we do more extractions, like in Bayonne, New Jersey. I think that we must have little Asia over in Bayonne. So extractions are necessary in some cases, but it has nothing to do with crowding. It always has to do with the face. Right? So is crowding an issue here? Those teeth don't look crowded, do they? But look at the lips. Look at the Ceph. Is she not protrusive? So we took out 4 bicuspids. 4 second bicuspids, which is my preferred extraction pattern if I have a choice. We'll talk about that more. Okay? Why I take out second bicuspids more than first bicuspids. Okay? And that's why we extract it. Because her face needed changing. Not so much her dentition. The teeth were relatively straight. She was just by max. How about this young lady? 26 years old, almost 27. She comes into the office, and she's got beautiful teeth. She's got this smile from ear to ear, and she had treatment twice. And I looked at the photos, and I go, man, why is she here? I thought she was here maybe to get new retainers or something, because I didn't treat her. She was treated twice before up in North Jersey somewhere, once in New York. Right? So when I walked into the exam room, she said to me, I said, well, what bothers you most about your teeth? Why are you here to see me? She says, I'm a teacher, I'm a guidance counselor, and when I take pictures with my kids, meaning the kids in school, I look like a monkey. And I was sort of like taken back. I looked at her and I said, well, you know, you're probably the most beautiful monkey I've ever seen. And that's what she was talking about. All right? So that was her chief complaint. She was treated non-extraction twice, but she shouldn't have been. All right? So we retreated her. 4 second bicuspids. Look how soft. And we didn't take her Hispanic heritage away from her. We didn't make her lips Caucasian, make her flat. We left her lips relatively full, but fullness that she could look good in, right? So we have the ability to do that for people. And yeah, that is a good-looking monkey. I wish I knew more monkeys like that. So let's look at an extraction case. I'm going to take you through mechanics now. So we're going to start our mechanics part of our lecture. I know there's a lot of experience Damon uses here. So I decided to do things a little bit differently. All right? we're going to look at cases, and we're going to look at some of the aspects of system basics or how we treat cases by looking at some cases. All right? So we're not going to just get into this boring layer by layer listing of what we do in our mechanics. We're going to look at some cases to understand the mechanics. Okay? So we're going to extract for the face. So let's talk about extraction cases. This is the back of my office. All right? We're out there. That's my son. We used to meet in the evenings on Tuesdays to look over some tough cases and decide what we're going to do or set up some insignia cases. This particular night, we both forgot our keys. So I'm looking for a rock. My son's standing around. So I found a brick. We're going to break the window to get in. He had a headache the next day. And so did I. So when do I extract? When the face requires it, bimaxillary protrusion. Extreme midline discrepancies. Setting up a case for surgery. But I don't do that very often. So we don't do a lot of surgeries, especially anymore. 2 reasons. Number 1, there's not that many surgeries necessary. And number 2 is insurance don't pay for it. So most people can't afford it. Right? To improve bone and tissue contours without negatively impacting the patient's profile. You just looked at that in the young lady who thought she looked like a monkey, right? We extracted. We didn't take her teeth all the way down her throat to make her flat or Caucasian looking. We just retracted her to make the profile pleasant. We rarely meet an AP requirement. Now, what I mean by that is the worst extraction pattern in orthodontics, in my opinion, because I've done it, is upper first bicuspids. We do that to compromise and reduce an overjet. I did that for years because I was frustrated with class 2s, especially non-cooperating patients. And I didn't have a good appliance to correct the class 2s. I had a great appliance called the Frankel, and when patients wore it, it was great. I got great results. But 7 out of 10 times I failed with the Frankel. Why? Because I didn't wear it. It's a very difficult appliance to wear. So I failed. And that's not a good ratio, is it? Fail 7 times out of 10, and succeed 3. You wouldn't be a very good orthodontist, would you? Wouldn't have a very big practice if 7 out of your 10 patients, it didn't work, right? So, closing space. How is it different in the Damon system? There's far less concern for anchorage. And I will prove this to you today. I take out a lot of second bicuspids because anchorage isn't a big deal. Anchorage is a big deal only if you tie down the front teeth. And you leave what? The molars in tubes. Because even though they're bigger teeth, they're sliding without friction or very little friction. And you've tied down all the teeth that you want to move. It's dumb, isn't it? When you think about it. Right? We're going to prove that to you. Far less concern for anchorage. Lighter forces and low friction allow muscles to help us. All right? So let's look at this functional effect. Watch these unravel. And look at the spaces close up. Didn't touch any. There's no space closure mechanics here. Just letting the teeth unravel and the lip muscle maneuver the teeth. You notice that this is all 6 months, going through round wires in these crazy crowded cases. You don't remember him. You're going to look at him later. But this is one of the cases that I would take 4 first bicuspids out. So there are times to take 4 first bicuspids out. But if I have a choice, I'm going to take out 4 second bicuspids. All right? Take a look at this. Look what happened over 4 months. How the space just unravels to the extraction site. Now, you notice, too, there was an impacted canine. So why would I take out a second bicuspid in this case? So you need to diagnose and treatment plan. Okay. Most times we have to work to close space, though. 75% of the time, we're going to have mechanics to close the spaces. And that's what we're going to look at. What are our objectives? Our objectives in an extraction case is to level the steel. Because we're going to do major mechanics here. We're going to have coils on the arch wire. We're going to be using elastics. And steel is something that we've got away from. A lot of people don't go to steel. They go to TMA. You shouldn't be doing that in an extraction case. You need the rigidity of steel to slide teeth easier. Steel, by the way, is the smoothest wire that we have in orthodontics. Very smooth. TMA has to have a friction. If you notice when you buy an arch wire, TMA arch wire, it says low friction coating. Because if you looked on a microscope, it looks like sandpaper. It's all these little pits, so they have to fill it in. But it still doesn't slide, nor does it have the stiffness of steel. So the upper arch, I go to 1925 posted. In the lower arch, I only go to 1625 posted steel. I'm a low force guy. 1625 steel in the lower arch is sufficient, in my opinion, because we have a smaller inner bracket distance, and you don't hurt people. You put a 1925 steel in there, that's tough when you have a shorter bracket distance, and it hurts. What's the alternatives to posted steel? We can put locks on the wire. We can put posts on the wire. And we did that early on because we had problems with the hooks. But Ormco fixed that. They use laser welding on those hooks, so I love those arch wires now. So we use them all the time. I don't want to waste time with Krypton hooks which slip sometimes. All right. So we level the line, including second molars. 1625 steel, like I said, in the lower, 1925 steel in the upper. So let's look at the extraction mechanics. First bicuspid extraction, we usually hook it up over top or back of the arch wire, right, of the molars. The second molars will travel with the first molars as long as you keep them out of occlusion. So you want to make sure your cases are disarticulated. And we check that at our visits with articulating paper. All right? Medium night-tight coils. In first bicuspids, I use a 9mm coil for the most part. Stretch with lig wire. Okay. In the lower arch, the same thing. You hook it over the back of the second molar. You can put it on the hook or on the arch wire. All right. 1625 steel, and let spaces close. There's your three sizes of coils: 9, 12, and 15 millimeters. We bend over one end, hook it on the hook or the arch wire. And then we tie it with lig wire over the back of the arch wire or on the hook and stretch it with lig wire. I used to take a 15mm coil and start with a 15mm coil. And then as the spaces closed, I had to go to a 12mm coil. And as they got even closer to being closed, I used a 9mm coil. So I was using 4 sets of 3 coils in every case, which gets expensive. Don't tell Ormco I told you this. Okay, you can use a 9mm coil and only use one. You stretch it with lig wire, okay? Don't get mad at me back there. All right, if I have a choice, I prefer second bicuspids. Let's talk about that rationale. There's an anatomical advantage to a second bicuspid. It's just generally it's a single rooted tooth as opposed to upper first bicuspid, which has 2 roots. It's a more conical root. It's in a wider alveolar trough. So what's the advantage of that? Okay, how about less likely to have a cortical plate fracture? Now, how many of you, when you write an extraction order, make any notations on it? Do you know what a dentist does or a surgeon does when they extract a tooth? The same thing you did in dental school. You get your fingers on the alveolus and you squeeze and crack the bone because they tell you to do that to help with the clotting, right? You think that helps us if we crack the cortical plate and compress it in there? No. That's why we have extraction spaces reopening, right? So here we go. We're moving the teeth like this, nice and bodily, And then we get to that cortical plate fracture, and this happens. We take the braces off, where do the teeth go? Back to their roots. We see extraction site open, right? It's just dumb. Likely to have extraction space reopening. So in our orders, we tell them, take out the 4 teeth, do not, in big red letters, do not compress alveolar socket. I want that, if they have a bleeding problem, suture it. Won't be crushing the bone on me. I got to move teeth through that bone. You can't move teeth through cortical bone. You need spongy alveolar bone, all right? So write that on your orders. How about patient aesthetics? Is that it? What's that mean? How many times have you taken out 4 first bicuspids and the patient walks in and goes, oh my God, how long am I going to have these spaces? I'm an executive on Wall Street. I smile, I look like I'm from Appalachia. Yeah? I can't have this. Right? So if you take out second bicuspids, they don't notice the space. Right? It's a huge aesthetic advantage. And I'm going to prove to you today that anchorage is not a major problem. Because muscles help with space closure. We have less friction. And every tooth is in a tube when we have passive self-ligation. That's what the Damon system gives us. Okay? So the anchorage mystery is this. If you put molars in a tube and you leave the other teeth tied down, isn't that dumb? The teeth we really want to move, we're tying them down. So every tooth is in a tube, not just a molar. Now differential anchorage applies. Does anybody know what differential anchorage is? Well, the Aussies should know back there, right? Differential anchorage is where studies done on bed cases. And they realized that molars, guess what, have bigger roots than bicuspids and incisors. And plus they have a tripoded root. So to move a molar against an incisor in a tug of war, the incisor is always going to lose, as long as the friction is the same. But if you tie down the incisor against a molar, then you have a problem. So the key is you don't tie down the front teeth that you want to move. Lowering anchorage is easy. If you tie down the teeth you want to move, you add friction to them, and the teeth that slide are the molars. So the objectives. We level to steel for space closure mechanics. All right, I did this. Sorry, this is a repeat. But remember, it's 1925 in the upper, 1625 in the lower. Uh-oh, something. Let me get quickly. All right, let's look at the extraction case. I don't know how that happened, but I apologize. Those same slides got sequenced. Sometimes when I'm copy and pasting, I get a little crazy. Yeah, and of course that's not going to open, right? Okay. Hopefully this works now. All right, this is Brittany. Now she was previously treated. All right? She's previously treated and she's got a TMD problem. Now she comes to my office with a TMD problem. You can see the little anterior open bite she's got. Teeth are really straight though, aren't they? Look at the class 1 buccal segments. Beautiful, aren't they? What's your biggest challenge when you bond this case? Not to mess up the posterior occlusion, right? Getting your brackets on in the right position. So we first told her, let's get the 8s out and see if that helps your TMJ problem. Well, it didn't, and we knew that, but she didn't want braces. So we extracted the 8s. All right, we let her sit around for a while, and the pain didn't go away. But there's the problem. Should she have been treated non-extraction? Look at her lower lip. Let's go back to that Ceph. Can't have the incisor laid out like that in a high-angle case. We'll talk about that a little bit more. What's the differential diagnosis here? We're going to lay it out. I call it the 90-degree rule. Okay? Now, this is not something you're going to find in the textbook. This is something from 40 years of doing orthodontics. When I have a high-angle case, IMPA the number 90 is the most important number. Now, I know the new norm, when I went to school, 90 was the norm. The new norm, when they did research, is 95, right? They did a whole bunch of orthodontic, non-treated normals, came up with the number 95. But I'm going to tell you that in a high-angle case, you want the lower incisor finishing at 90 degrees or below. 90 degrees or below. So if it's a higher high angle, you would like to even have it lower than 90. Now, it doesn't mean you can't have it at 91 or 92 and have a nice result. I'm giving you a ballpark number, okay? So you're going to see that in this case. That's where it should be. Now, you saw she didn't have crowding, but where am I going to get the room to move that incisor that far back? All right, so let me give you a differential diagnosis. You have an extraction case, and the incisors at 92, okay? And you have 7, 8 millimeters of crowding in the lower arch. Can you treat that non-extraction in a high-angle case? And the answer is no. Don't even think about it. 92 on the incisor with crowding, just extract it. And take out 4-second bicusspids. That's why she has TMD. Everybody in this room knows if you don't have disocclusion in the anterior when they function, they're going to ramp off their posterior teeth and they're going to cause a problem in their joint. Everybody in this room I know knows that. That's the reason for the TMD. When you open a bite, what happens to incisors? They flare, right? When you close a bite, they deepen. So what do we need to do? We need to extract and close her bite. Give her anterior disocclusion. Okay? Perfect class 1 buccal segments, but it doesn't work for her. Not with that skeletal pattern. Take a look at that. Now, when we get into more mechanics, in extraction cases, we put high torque on all the canines. That's imperative. All 4 canines should have high torque because when we retract them, they're going to dump lingually. Now, you're going to look at this and say, well, you did it on the lower, doc, but you didn't do it on the upper, right? What bracket's on there? Standard torque. The reason being is we didn't have high torque yet in the clear brackets. That's one of the original set of brackets. So knowing that going in, I have to compensate for that, right? Okay? But high torque on the canines, you want to keep them upright. Teeth dump into the extraction site. If the tooth gets caught up on the lingual plate, it's harder to close spaces. So you want to keep them upright. That's why we put high torque on all 4 canines. Okay? We extract. Notice I didn't cross the extraction site in the lower. This is only 014 arch wire. I cross only in 016 or 018. Okay? Disarticulate. Turbos, every case. Molar turbos. In this case, they're going to be bilateral in high-angle cases. You want to control your vertical in a high-angle case. So on the occlusal surface of the lower 1st or 2nd molar. Unilateral, we sometimes put a unilateral turbo. We'll talk about that in a different case, just as a temporary turbo to disarticulate. We would do that, let's say, for an example, in a little bit of a class 2 case. We have a mild class 2. We can't get anterior turbos on in a deep bite case, right? Because they're not going to hit them, or you're going to have to make them so long that the patient's uncomfortable. So we put a temporary turbo on. Anterior turbo, we've never put on in this case because it increases vertical. We must control vertical. You can put them on the centrals when you're on anteriors. You can put them on canines. That's what we do in a class 2 case as we move forward, right? Start on a molar, temporary turbo, move to the canine. As we reduce the overjet, get to the anteriors. Okay? Okay, so there's our turbos. You can put them on the first molars if your molars are connected, or you put them on the second molars. Okay? Notice that the wire is cut and cinched. But also notice that the wire is cinched well behind the bicuspid, right? We need these teeth to be able to float and move. So you don't want to cinch this real tight. So you want to cinch it with some room for the teeth to move. The molar turbos are pink gel. It's called Triad. I use pink Triad gel. This articulation, this evidence, this is the open bite she came in with. Look what she looks like now, the day we send her home. We really opened her up, didn't we? Well, it's easy to do that when you put molar turbos on, right? But you need to just explain to the patient that this is temporary, to chew softer foods for the first few days and chew slower so they don't choke on the bolus of food. And as long as you explain that to them, they'll understand. But just don't do this and send them out, and they go and try and eat, and then they hate you because they can't eat, all right? So it doesn't take long for it to close down. Remember, I started the elastics on the second visit here because I didn't have a full arch wire in the lower. So we started a vertical elastic here on the sides. But look at the bite closes down. Second visit back. Not an issue. All right, let's talk about the bonding protocol on clear brackets for a minute. On anteriors, we always use Solo. On posteriors, we use Multibond, which has acetone in it. I don't care if you use those same brands. All right, this is the Ormco for Solo. And Multibond, I like, Solo has denatured alcohol. It doesn't evaporate as well as does the acetone, right? Now, on clear brackets, very big, important point. I don't use any primer. So we etch the tooth, we wash it, we dry it, and then we have that frosted tooth that we'd normally then put a coating on, right? We don't. We bond right to the frosted etch with the clear bracket. Okay? Don't have to, it's strong enough to hold, and when you have to reposition a bracket, you can pop them off without breaking them. And you put it back. And it's not uncomfortable for the patient. But trust me, they will not debond. All right? You don't need to do it. It's strong enough bond for the anterior teeth. Okay, so those brackets were bonded to the frosted etch surface, no primer. Right? So look at the initial response. The bite closes down. 4 months. Second visit back. This was started. First visit back, the elastic. Didn't start it here because we didn't cross. Early elastics, huge. We're going to talk about early elastics today. All right? Early elastics is the biggest change from the original workbook. Early elastics help us do things that we couldn't do before. And you're going to see that as we get into more complex cases toward the end of the day today, and especially on Friday, the effect of early elastics. It's huge because we're wearing them on super elastic wires. Right? They're softer wires. So we're going to show you how we learn to do these things because we saw different responses. How occlusal plane changes. And we get these dramatic corrections in very difficult cases because of early elastics. Okay? Again, this was a change from the workbook, the original workbook. 8 months in, we start our retraction coils. Why did it take me 8 months to get to retraction coils? Because I had the level to steel, remember? 1925 and 1625 in the lower. You don't have to be in a hurry. There's our retraction coils tied with lig wire to the hooks, to the posted hooks on the arch wire. Now, in this case, we have molar turbos on, correct? So our retraction coils have to go back to the second molar, not the first molar, because they're not going to track with heavy occlusion on the turbos. They're going to sit there, and the first molars will slide, and you'll get a space between the molars. So here's where we used a 15-millimeter coil. We used a longer coil, attach it to the second molar, and stretch the lig wire, because we want the second molar retracting. Also gives us more anchorage, doesn't it? Because we've engaged 2 molars now against how many anterior teeth? 8. And believe me, those 2 molars anchored on each side are a lot more powerful anchorage than the 8 teeth out in front with single roots. Okay? So we're continuing some elastics, mostly in a class 2 with a little vertical component. Remember, we want to close her down. She's high angle. We want to close that bite because of the TMD. All right? So that's the different setup with second bicuspid extraction. We're going all the way back to the most posterior molar. You hook it over the wire or on the hook. I don't care, your choice. All right, all the way back. Same for the lower. Second molars. These are the turbos. So those molars will not track if there's heavy occlusion on them. So you must go back. That's where the 15 millimeter coils, that's where we have them. They're built to go back to second molars, okay? And you can have a choice. Some people like to put molar turbos on their upper molars. It's okay. Just as long as you disarticulate on the molars. So some people put it on the palatal cusp of the upper. I just like to see them. I like them on my lower second molars. I can look in there and see them all the time. I used to use white, like composite on the second molars, and then I had trouble finishing my cases. I said, why can't I close this bite down? Because the dummy left the acrylic, the composite on the turbo. I left it on the molars, and I'm saying, why can't I get the molars to seat? So we all make dumb mistakes. 10 months in, we're continuing retraction coils. And let me tell you, let's look at this sequence right here. This is what we do in extraction cases. The first thing, they come in, they sit in a chair, my staff checks them, and they cut the excess wire in the back, right? Because the wire is coming out the back as the space is closed, right? So we cut all 4 quadrants, we cut the wire. The second thing is I sit down and I check 2 things. I check if the coils need to be reactivated, which not every visit they're reactivated. They don't have to be because they're stretched out and working. And the next thing I look is to see where my canine is. Keep your canines class 1 in these extraction cases. All right, you see this? Looks like this is going to be marked on my chart. Watch this one. You see I'm on the post here? If this thing goes more class 2, I take it off the post. Don't tell Dr. Damon this, because we're supposed to do en masse retraction, right? But you can cheat if it makes sense, right? I would take the coil and put it on the canine for 1 visit to pull it back into class 1, and then go back to the post. Because orthodontists think best in class 1, don't we? You don't want to close all these spaces and still have class 2 canines or end-on canines, because now you have to have the patient wear elastics to fix the final occlusion, right? If you already have class 1, keep it class 1. All right? And that's how we think. We think in class 1. It's the same thing in mutilated, let's say adults with multiple missing teeth. Your treatment plan should be this. Consolidate cases in the anterior. Get your canines class 1, then get your anteriors class 1. Then we can think what we got to do in these mutilated cases. They have a couple of missing molars or missing bicuspid. Class 1 canine, class 1 anterior, then you plan your mechanics to finish the case. Because we think in class 1. Okay. This is huge. This is what we want to accomplish. Occlusal plane change. Look at it. You're not going to change the mandibular plane angle because you took out second bicuspids. You're not going to get auto-rotation of the mandible like we can do in surgery if we impact the maxilla. What you want to do is keep the mandible from opening. All right? But you will get a nice occlusal plane change. And you're going to see how important that gets when we get to class 3 cases. Okay? So the occlusal plane change is huge. Continue our retraction coils. Now, here's the next thing. Remember, our wire in the bottom is only 1625 steel. The molar will dump. We don't want that to happen. So as we're going through, we put a little V-bend. I take a 3-prong, right, and I go in there intraorally, and I just squeeze the wire a little bit. Just a gentle squeeze so I can see a V-bend. And I do it on one side, then I do it on the other. Now, I don't take out the arch wire to do that. Taking out arch wire takes too much time. All right? So clinically, to be efficient, I put the V-bends in. Now, they're probably not exactly equal. Do you think that matters? Doesn't. Because we've got all that play in the bracket slot, right? So it's not going to matter. If I see one is dumping more than the other, I squeeze the next visit, I squeeze it a little more. That's all. All right, so you don't, the easiest cases to treat when you get into extraction cases, and you get this mechanics set up, you have nothing to do except cut the wire in the back, check your canines, reactivate your coils. The cases just go nice and smooth. If you've taken the time to set them up that way, and you have everything in class 1, and you're thinking in class 1, because I always know where I'm at. I see plenty of cases at university where they start closing spaces, and they finish all the space closure, and they still don't have a class 1 canine. And then they got to wear elastics to get that done. It makes no sense to me to do that. Okay. So, note the maxillary canine position. Now, in here, we're using non-latex elastics. I haven't found a good brand yet, so they're pretty much worthless. They stretch out within 30 seconds of the time you put them on, right? If you have non-latex elastics. So essentially, the elastics are an exercise in futility here, right? But as long as you control your case with the coils, you won't have an issue. So we continue our retraction coils. And you see, we're staying with the class 1 canine. And we're controlling the lower molar with the V-bend, so it doesn't dump on us. I equilibrate. If I think those molars are hanging down a little bit, we equilibrate them. Okay? We'll talk about bracket position this afternoon so that doesn't happen. But I check also my canines. Notice on this side, the canine is not touching. Here, the canine's hitting that bicuspid, which is going to slow its progress down of space closure. So we'll touch grind the bicuspid and canine and the upper canine. Just equilibrate it a little bit to keep it out of a heavy occlusion. You can see the occlusion here. Not on the turbo, it's on the cusp. Okay? So we equilibrate that. We continue elastics and coils. See how nice and smooth everything is running when you keep things class 1. Okay. See this chain over and chain under? We were teaching this for a long time. What do we tell you to do? Chains under when you're closing spaces. When you're done closing spaces, put the chains on top so you don't cause rotations. Well, I know now that that's bull. Pardon my French. Does everybody know what bull means? It's not true. And Friday, I'm going to prove to you why, with clear brackets, look at that chain. Does everybody see that that's no space in between links? Now watch. Do you see any rotations occurring there? Where do you see Friday? Friday, I'm going to explain to you why I didn't have the problem so many people had with rotations and finishing. And I didn't get it myself. I didn't understand myself why I wasn't having a problem and people were telling me to have all these problems. Well, I'm going to show you on Friday why. Look at this is clear brackets. I want you to look at the occlusal. Where do you see any rotations? I have the tightest chain possible, no space on that. You saw it. No space in between the links. Unclear brackets, and the teeth are not rotating. You'll find out Friday why that doesn't happen. I'm not giving it away yet. Because you have to show up Friday morning. I think I start at 6:30. No, I'm only kidding. I'll be here at 8 o'clock. But you're going to understand fully what the chains do, why we have problems with rotations, why we have problems in finishing if you don't set your cases up properly, okay? But there are no issues with rotations, and I'm chaining with heavy chain underneath there. Unclear brackets, remember that. And everybody had problems with clear brackets, right? Except me. I'm serious. And people would tell me this, and I would say, geez, I don't see that problem. And I felt sort of incredulous, right? Because, I felt like people thought I was lying. I'm telling them to sell them the Damon bracket, right? I'm just selling the bracket. No. But I now understand why I didn't have problems and people did. And that we're going to discuss thoroughly on Friday. That's what we call troubleshooting. Where do we have to troubleshoot? What do we have to do to avoid problems? How do we fix problems when we have them? You have to understand why you have the problem. Then you understand how to fix it. Okay? So we finished Brittany in 18 months, which is a typical extraction case in my office. Right? 18 months is a pretty reasonable time for a 4 bicuspid extraction, I think. And I take out more second bicuspids than first bicuspids. But it always comes down to diagnosis and treatment plan. I think you'll agree that she's got a really nice finish. This is the day we don't usually take records the day we take them off, but she was leaving for Puerto Rico on vacation. So we took the records because I was going somewhere to teach. I wanted to show her case. So you can still see the coil imprint. Let's just go back one slide. Take a look at the upper arch form. See the change? I didn't do that. We'll talk about that as we go through today. How did that arch form change? Why did it change? Okay? We'll look at that today. Eights were extracted, no effect on TMD. 4-second bicuspids extracted. Bite deepens, give them anterior overjet. TMD problems disappeared. The second visit, her TMD problems, remember I showed you the second visit where the bite closed down? Gone. Her TMD problems were over. All it was the anterior, she needed anterior disc occlusion. And it was gone. Because somebody treated her the wrong way. You can't have incisors out here. You can't have an open bite. It's a non-functional occlusion. So watch this. We go from here to here. I'm just going to go back and forth with my clicker for a minute. See the lower lip? Close look. Look what changed. How much did the lower lip change? Not a lot, right? Look at the lower lip. Look at the incisor upright. That's 4-second bicuspids. No anchorage preparation. But that's what you can do. Look at the reduction and look at the lower lip position. So that's the 90-degree rule, right? My incisor is now at 90. And look what that does for her lower lip, and look what it does for her profile. That's why we do it. That's why we must control vertical. Okay. All right, so let's look at some of the basic mechanics of the system. Okay, so we're going to take our slide. What's the treatment protocols that we go through? We're going to review that. And I know a lot of you use the Damon system, and I recognize a lot of faces of people that have used it for a long time. But for people that have not been using it for a long time, we're going to review the protocols. Remember, it's not a cookbook. It definitely does not use a lot of friction, muscles, and we use light force. Now, let me make one more statement about light force before we continue. Today, I rarely treat a case with more than a 2-ounce elastic, all the way through. Occasionally, on a tough adult, I may go to 3-ounce elastic. In the Ormco system, That's quail and parrot, right? 2-ounce elastics. So, and then dolphin is a 3-ounce elastic. I rarely go, just to let you know where we're going with light forces. You don't need more than that. What you do need is the patient to wear the elastics. So if you're not seeing a response with a 2-ounce elastic, they're not wearing them. Now, does it make any sense if I ask you to wear 2-ounce parrot elastic, right? And you're not wearing the elastic and your teeth are not moving, and I come over to you and I give you a 3-ounce elastic. Because if your teeth hurt with a 2-ounce elastic, then I give you a 3 or a 4.5 or a 6-ounce elastic, how does that make any sense? If they're not cooperating with a 2-ounce elastic because their teeth are sore, how does it make any sense to give them a 6-ounce elastic? But that's what we're trained to do, right? We're trained that if it's not working, hit them again. Hit them again. Because we're trained to make it happen. Let it happen. Get your patients to cooperate. That's the key. All right, so let's look at the system and the basic mechanics. All right? We have variable torques, and you must use variable torques. You need to inventory high, low, and some standard brackets. We use standard still. But high and low torque are essential. In the first 2 stages, they're super elastic. We use light round wires. Then we use light rectangular wires. Very important to use the copper nitrile wires. I know a lot of people go in and buy cheap wires from some other company, right? But copper makes a big difference in the force level of the wire. The copper rectangulars are baked at 28 degrees. You can change the temperature with copper by adding that alloy. A standard superelastic wire is around 17 or 18 degrees. It's a lot more kick in the wire, a lot more force on the teeth. So spend the money on copper nitrile wires if you want to have the full benefits of the system. Then we go into major mechanics, and our 4th stage is finishing. All right, that's the wire sequence, right out of the workbook. Okay, 014, 1425 is our first rectangular wire. 1825 is our second rectangular wire, copper nitrile. Then we move into posted steel. 1925 and lower, 1625. That's my routine in an average case. But not every case is average, is it? There are some times I go through 3 or 4 round wires. So we'll talk about that. You can't just go with an 014 in every case. But look at some of the literature that's published, anti-Damon literature that says it doesn't work. Read the synopsis, what they do. They start out using the workbook. They put an 014, 1425, 1825, 1925 steel. Well, if you do that in every case, sure enough, you will fail. You can't. I can tear that apart all day long. So we don't use any rapid palate expanders. I haven't used a rapid palate expander, I think since I told you 1982 was the last one I used other than Sarpi. Okay? Because I understood that the transverse happened in the Frankel without doing anything. So I got rid of expanders. No headgears or distalizers. I got rid of distalizers too when I gave my daughter a distalizer. And even in my early years, if you looked at some of my early cases from 1997 to 2001, let's say, I was still using some distalizers. Okay? And that Dr. Damon took me aside and said, try one without it. I just couldn't figure out how I would get a class 1 because I didn't understand the concept of the transverse yet and how much room I would gain. Okay? All right? So get rid of your anchorages. Other than TADs, which I know we need sometimes, we don't use anchorage. So there's no TPAs, no Nance buttons, because that impedes the ability of the arch to widen, doesn't it? If we put a Nance in or a TPA, right, and it impedes the ability of the arch to develop. In early treatment, sometimes I still use an expander, right, because I don't want to put braces on a 6 or 7-year-old in bilateral crossbite or has a crossbite with functional shift. But I use this expansion screw. It has nickel titanium coils inside of it. It's made by Forestident. All right? And it's very much like what Williams and Murphy published with this lab-made appliance. These are night-tie coils. He builds that. When he cements it, he compresses this thing, and he cements it. When you turn this jack screw, it's not a jack screw. When you turn the screw, it does not open up, doesn't jolt the bone. It compresses little coils, night-tie coils, inside the screw, just like this does. All right, so we give a patient an early treatment. We give them this expander. It's called Memory Expansion Screw Type S. It's made by Forestident, and I use AOA Labs. They use that appliance for me. And we turn it twice a week, Sundays and Thursdays. And you get light compression. All right, that's the screw. Memory expansion, if you want to take a picture of that, this is the Forestident screws. And there's two of them. We use mostly Type S, and there also is a Type N, which is a little bigger. This gives us 8 millimeters. That has 10. So that's the screw we use. So when you turn it, you don't put pressure on the suture. You don't jolt the bone. You just compress the coils and let them work gently over a period of time. All right? So we start with an 013 or 014 in an 022 by 27 slot, right? And it doesn't overpower the biological system. If what? If we minimize friction and binding friction. Well, friction is minimized because we have the passive self-ligating system, right? But we need to eliminate binding friction or minimize binding friction in a lot of cases too. And that's where we get into trouble making mistakes, because we engage too many teeth in the wrong case. So we're going to talk about that all day long. Phase 1, 014, 013 are our typical wires. All right? And we use as a backup for our second wire, we're going to use 016 or 018. Because if we have a severely crowded case, I'm not going 014 to 1425. We're going to sequence through several round wires to let the arch develop. So here's a typical sequence in a very crowded or a very narrow arch case. Typically, if I start with an 013 for 8 to 10 weeks, my next wire is an 016. This is really a tough formula. If I start with an 013, I double it, 016. If I start with an 014, my second wire is usually 018. But doesn't mean that I won't use 4 round wires in a really constricted case, or 3. So I may use an 013, 014, 016, or 013, 014, 018, based on how the patient's teeth are moving. We'll talk a little bit about that. Dr. Damon taught us that. He said, read and react to what's going on in your case. Read and react. So if the teeth are not moving, don't hammer them. Stay with light wires a little longer if they're not responding. Don't try and make it happen. Let it happen. Okay? Just let them sit longer. Okay. Activated appliance too frequently does what? Short circuits the system. That's by Bill Profit. Now, everybody in this room, I know, has witnessed this. This is what Profit's talking about in his textbook, is the patient that you strap up, right? You put this case in, you crazy, all this crowding, right? And you got stuff, and you send the patient home for 8 weeks, and they don't show up for 8 months, or 10 months, or a year, because they disappear. And then one day, you come into the office, you look at the schedule, right on the top of the list is Johnny. And you go, oh my God, I haven't seen that kid for a year. So you know this is going to be a nightmare. He's going to come in, teeth are going to be all over the place, broken braces, the whole bit. He walks in the office, he sits down in the chair, and you look at him and you go, what? He looks great. Teeth have fallen into place. Everything looks fantastic. And what did you do? Nothing. So who did that? It's the muscles. Even if in conventional mechanics I saw that. Because if you have elastics on for 1 year, what do those elastics look like? There's no force in them anymore, right? They're all deteriorated. Some of them may be missing, but they're still there. But the teeth still move because you took away the friction, right? So we all have seen that. So don't be in a hurry to keep activating these things. We have a lip upper effect that we see of the musculature. The tongue becomes a player. So when we take away, we had a little force on the outside, the tongue, which was overpowered by the muscles, the lips and the cheeks, now becomes a player because we're helping it by putting a little force on the outside. And it's also really important to disocclude. You don't want the teeth in contact. Now, people argue with me all the time about that, okay? Because as you're sitting there listening to me, all right, I'm going to pick on you. As you're sitting there listening to me, are your teeth touching? No. You're in your freeway space, right? You're open, you're relaxed, your jaw's hanging open. Unless there's somebody who doesn't like me, they're biting down and gritting their teeth, right? But for the most part, you're sitting there relaxed and your jaw's hanging open, right? Why do we need turbos then? Because at night, I wore braces twice, in my late 20s and my late 50s. And I will tell you, you grind and clench your teeth at night when you have braces because your teeth are constantly changing position. You ever have a high filling? All right? So how many times do you think we're getting high spots in our dentition during the process of moving teeth from point A to point B? That's why they hurt. You wake up in the morning and go, man, these teeth are killing me. That's why you need bite turbos. Disocclude, let them move freely, and let the muscles have their maximum effect. Okay? Here's a perfect example. Put a little light wire in there. 8 weeks, the canine seats. In conventional mechanics, I would have watched those teeth flare. And what's the difference? Look at this. Take pictures of your strap-up to show your patients of cases. Not only show them a case like their case, but show them the first visit. You see how much worse this looks like? The teeth look like they're falling in to the tongue. This is what you're diagnosing. This is the dental alveolus. Those teeth are extremely collapsed. We don't have to expand them. They're just going to upright. And there's space occurring. You can see the teeth have uprighted. Who did that? You think it was that round little wire, 013 or 014? It's the tongue on the inside helping them, right? All you've done is change the balance of forces because you took a little light force on the outside with that wide Damon arch wire, put it in there, and it kicks these a little bit, and the tongue now wins the battle over the lips and the cheeks, okay? Changing the balance of forces. That's all it is. All right. Second phase, the second wire, first rectangular wire is 1425. Now that could be the fourth wire in a really crowded or constricted case, right? We could have gone through 3 round wires. This is the key wire, I think. 1425, leave that for 8 weeks, always. The 1825 you can leave for 6 weeks or so, and then go to repose, okay? But this is where the final arch form is typically established. And this is one of the most misunderstood things and the biggest mistake I see made in cases. Because everybody's getting this wide arch form, teeth are getting tipped. If you tip teeth to expand them, that's going to collapse. I will give you a written guarantee of that. But if you just upright teeth, like Melvin Moss told us we could do, then you will have a good, stable result. Reasonably stable, okay? So you want to have that arch form develop. That is the Damon arch form. It's not what we treat to. That is just the arch wire that we have, okay? It's patient-specific, determined by their muscles and function. All right? All 4 treated with the Damon arch wire. Why are they all different shapes? Because we altered the arch after the 1825. That's as much as I could get out of this case. Same with the lower. Look at those arch forms, all treated with the same wires. So why are they all different? We don't clone these patients. Look at initial and final here. Big difference, isn't it? In the arch forms, big change. So we must modify the final arch wire in the individual patient. It's established by the balance of forces changing. form occurs from these high technology wires. We call them superelastic. And then you must modify the arch. We're going to talk about modifying the arch after the break. I think we're supposed to break around 10? 10? All right. So we're going to have a half-hour break. All right. And then we're going to talk about, we're going to continue the system basics, and we're going to start looking at some of the basics through cases. I'm going to show you what we're doing and why we're doing things, instead of just reading it out to you. Okay? All right, so everybody, it is a few minutes after 10. Everybody, please be prompt and be back a little before 10:30 so we can get rolling. We got a lot to do, okay? Enjoy your break.